Right, good afternoon, everybody. Welcome back to the next session in the programme, which I'm delighted to start to moderate. First, I guess, many thanks to Claudia, to David, to Maurizio for the invitation to come. It's the first time I've been to the I-ELCAP meeting. I hope it's not my last. And also congratulations on the timing. You know, just organising a meeting 48 hours after the UK government's agreed to do lung cancer screening, I think was a masterstroke. So well done. And I hope just to tell you a little bit about what maybe minor role we played in that over the last 8 years or so. So I'm a pulmonologist by background. I run the lung cancer program in a large cardiothoracic centre in Manchester, responsible for about 3.2 million population. That's the backdrop. Now, of course, the announcement on Monday was not always as it was. Back in 2015, when we just had the result of NLST, I was roundly criticised, and the rest of the team roundly criticised for even daring to think we should launch a lung cancer screening program. We have about 120 deaths per 100,000 in our local population from lung cancer. It's the leading cause of premature death in the under 75s, next to coronary disease and chronic respiratory disease. And of course, they're all smoking related, aren't they? So why wouldn't we want to look at a program that addresses that? And we do have a 10-year life expectancy inequality across the city, from the least deprived to the most deprived, where obviously lung cancer is a major driver of that. When we were starting to think about this, because we were pariahs, because we were going out of sync, because we were bucking the trend, we wanted to approach this in a professional way, and we very much went back to the principles of screening to start with, and I think that's a good place to start if you're going to launch a program. So we went back to the WHO, we went back to this document that was updated really over the last 40 or 50 years to think about what you should do, and we've touched on a lot of these concepts already today in relation to screening. And it's not just the act of getting people onto a scanner, it's how we make sure that having detected an abnormality that might be cancer, we can put people through a system in a timely fashion and we don't harm them in any other way. One of the key things up here, I think, if I get to the right one, is about the identification of the population, which sort of comes to the uptake issue here. I can't quite see what I'm at, even with my glasses on. But the bottom line is that you should be able to reach those. Yes, it's not showing. You've got CT, that's absolutely fine. We know the age range, but how are you getting your screening tool to those hard to reach populations? And that was a focus of our concern. And I think one of the editorials at the time, from an international collaboration really, was this document, which really said the obstacle to screening is getting to that hard to reach population. So, you know, how do we try and address that? I mean, I think one of the key things of running a successful program is having lots of people with expertise. I might class myself as a fairly good chest physician, knowing a lot about lung cancer and diagnostics and such like, but I probably know very little about communities and community engagement and how you promote these programs. I'm not a public health doctor. I'm not a primary care physician. So these were key people to have involved in our implementation group. And we're fairly simplistic in the approach. It's fairly proud. And one of my Swiss colleagues was talking yesterday. I liked what he was saying. Very, very passionate, but dogged and determined approach to this. You know, there is a lot of fear of cancer, lung cancer in particular. Many of you'll see some stats of the program we ran. But about 1 in 5 participants had a family history of a first-degree relative with lung cancer. And that probably means that their experience of lung cancer was awful, died very quickly. So, and most people, even at 60 years of age in these communities, do not expect to live much beyond that age. So as Ella was saying a minute ago, why bother? So the education of populations is important. I think we're seeing now that people have gone through programs, now that people have had operations, they're talking to family, they're talking to their local communities. You're seeing people engage more in the next round of invites that go out. So I think as programs mature, hopefully, you'll see an increased uptake. We coined this thing called the lung health check. And that's because the patient groups that were working with us were basically saying it's too, thinking about cancer, thinking about that is just too scary. Don't like it. So this was seen as a more holistic, more friendly engagement tool. And to be fair, we were partly told by the National Screening Committee that we weren't allowed to call it screening. So we had meddlers in London telling us that, we can't do it a certain way, which I was reacting against at the time. But actually, it's worked out, I think, to be a fairly positive thing. Somebody was showing earlier maps of lung cancer incidence, lung cancer mortality, and they do overlap exactly with smoking prevalence. But equally, they overlap perfectly with maps of deprivation. And certainly in the UK, deprivation of lung cancer is very tightly linked. So how do you get people who have a minimal disposable income, who don't have sympathetic employers, who don't have access to cars, to come to a screening location? Well, the obvious thing to me was to put the screening location next to them. So we designed our mobile clinic to offer that very service. If they couldn't get to that for whatever reason, we paid for their transport. We paid them a taxi to go. But obviously, most of the time, we put them in convenient locations, supermarket car parks, on main bus routes, main travel fairs. Again, all looking at the community experts who knew how their communities moved around. So mitigating travel distance, mitigating cost. And also, and I think it was Vicky who was just mentioning this before, if you're eligible for screening, you get your screen there and then. It's a one-stop shop. It's that moment of opportunity. We know in the UK, since we did this work, that lots of other centres have done the easy thing. They've said, well, we'll do a telephone call and the health check, and then we'll send them to hospital for the scan. Well, 15% of people who are high risk for lung cancer do not turn up for that scan. Okay, so it's a message, I think, that you can, don't do the easy thing or the only thing we understand. Do the hard thing and get it right. So that immediate access to CT is important. We also, because healthcare settings are really scary to patients, we wanted to make ours a little bit more friendly. A lot of patients believe that CT is very claustrophobic. And certainly on our original pilot, the standard CT scanners, mobile platforms that go around, you can barely walk around the CT scanners. They're very tight for space. They're not as claustrophobic as MR, obviously, but this clinic this is our clinic here. It's outside the Manchester City football ground. This is the clinic itself with expandable sides. This is where we see all our patients, do the health check. They've got access to research and tobacco dependency counsellors. And the CT scanner at the back here. And this was an ultra low dose CT scanner. I think the first one that Siemens deployed anywhere in the world at the time. So again, trying to make sure we're mitigating some of those harms at a population level. Just one of the other things, I suppose, the evidence base at the time was very much supporting this risk stratified way of doing business, and in terms of getting to the hard to reach. That clearly means you're picking people at risk who truly are at risk, and therefore you should have a scan. So that's a great tool, not just in some of the research studies. Obviously, there's lots of worried well, and certainly in NLST, I think there's a large proportion of patients that are probably not as at highest risk, and certainly in UKLS, the average deprivation sort of index was about 6. Which is more affluent than not. And as we've evolved, we have this, and I think this is important about your service, that your patients who are really positive about the experience go back and tell people that haven't engaged. If they have a really negative experience, they'll go and tell them, don't bother, it was awful. So that thing about arguing about shared decision making and all of that, if they want the scan, and you sometimes convincing them not to have the scan, that's a really negative thing. And I think most of our patients who are considered to be lower risk are really disappointed that they didn't get a scan. I'm no expert in this. I mean, this probably is a bit of obviousness to some extent, but wherever we go, to whichever site, about 6 to 8 weeks before, we're doing a lot of social media, print media, online media, trying to get to community groups, just trying to say, this is coming. If it hits, lands, pick up the phone, make the appointment or confirm the appointment. And you can do lots of measurements about social media activity and how impactful these things were. But I think it's hard to say which one's better than another, because I think the demographics of 55 to 74-year-olds, I mean, some people engage with social media, some don't. So I think it's a panacea approach, really. But I think in Manchester, we have over 200 spoken languages, which staggered me. I didn't know that. I mean, it's ridiculous. So how on earth do you send your invitational materials out to that number of languages? So I think things like websites are really helpful, because you can click a button and you can change it to one of those 200 languages pretty easily. So little things like that, I think they all help. And then just getting it into the community groups. So you went to an Asian group, well, the Chinese groups and Asian group, but the Asian groups in particular, where they smoke a lot of shisha, that's 100 cigarettes in an hour. And they think that's really beneficial to their health. So we really upset them by really contradicting that. And that's a real cultural thing for them, shisha, and sitting around and chewing the cud. But it's an important part of their education. And then do other little things, really. So I mean, the family fun day with an inflatable set of lungs, and integrating some exercise into that, and using your lungs, and just trying to be really positive. That was a very well attended event. Lots of street banners. This was obviously like when you had the Olympics, you had these things up, but you can use them for all sorts of things with your local council. Good materials that patient groups feed into is important. The average reading age in the UK is about age 8. So, they shouldn't be written by me. They need to be written by people who are, capable of dumbing messages down. And again, media and sign language for obviously visually impaired people, deaf people. So, I mean, I'm hoping you've all heard a little bit about the Manchester program, but I think this is the impact of what we did. All right. So that's the location. That's one of them. We had 3 other supermarkets we went to. I've talked a little bit about this. The community-based, it's the lung health check process. And that's very much focusing on lung cancer risk, cardiovascular risk, spirometry, and smoking cessation. Those are the 4 pillars of what we did. And having done that, and we presented these results at World Lung a while back, we got about 4.5% of people with lung cancer over the two scanning rounds a year apart. 80% of them stage 1 and 2, 90% having radical curative treatment. And we've talked a lot about the added value to this, but I think 33% of participants were at risk of coronary disease by a risk calculator called Q-risk. Cardiologists in the UK are not interested in coronary calcification if you do not have chest pain. But a third at risk who need to be on a statin but not on a statin. And 10% of people with symptomatic airways disease at risk of exacerbation and hospitalization who were not known to their primary care physician. At a year, we had about 90% of people coming back, which I think, that's not a bad figure. I don't know what the optimal would be for lung cancer screening, but I think as a first stab, it feels pretty good. And then 1 lung cancer for every 23 CT scans we did. And we were averaging around 30 a day. That's quite an impact in the local community. I talked, the index of multiple deprivation is a measure we have in the UK, and you can really drill down to streets and localities for that. But we know, just to say, are we confident that we got the hard to reach population? So this was our metric. So pretty much 80% were in the lowest quintile for deprivation who access this service. And the UKLS, as I said before, is around about the 6th decile. So research does this to you, and therefore proper implementation in a clinical service, addressing the issues about access, hopefully means that you really get, and probably why we saw such a large increase in lung cancers diagnosed compared to the research trial. As I said, 1 in 5 had a family history, 1 in 4 were exposed to asbestos, majority left school without any formal qualifications. So quite a group, and I think we did a fairly good job of engaging that group, and I think that community-based location was part of it. It's always nice when you hit the newspapers. This was in the Daily Telegraph. which is interesting. But we just did a little bit of work on the trucks in terms of questionnaires about the location, and it's perhaps reinforced what was being said to us by various patient groups, is that location was important for this cohort. It was important for deprived populations to not have to go to hospital. And the worrying thing is that if you're in the most deprived and still smoking, you're the most likely not to go to hospital. So the most needy, if you like, is put off by the location. When they were quoting reasons why they wouldn't, then it's travel and cost that tends to be the driving force. So that's the sort of backdrop for, to some extent, why I'm sort of talking about optimizing uptake here, I suppose, because I think we did a reasonable job as a first stab. But obviously we have an excellent faculty to discuss some of those important features, don't we? So I think most people don't need an introduction.
So my slide just shows some of the factors that influence screening uptake. So some of these factors have been published or discussed by other people already. So I'm just going to focus on one factor that I think is very important, is a primary care provider knowledge and also involvement of them in the screening program. So before we roll out the BC lung screening program, we intimately involve the primary care providers. So we publish papers in the Family Practice Journal, in the local Medical Association Journal. That we have CME modules and events. So just to get them up to par with the BC lung screening program. We also let them know that we need them to be intimately involved in the screening program, not to check off a script like a laboratory test to send a patient to screening, but we really need them to be involved in pharmacotherapy for people who are still smoking. So we know that 40 to 50% of the people coming to the screening program are still smoking, although 10% of them in the general population at that age group is still smoking. So we want them to increase the smoking cessation rate. One thing they can do is to provide pharmacotherapy that can double the quit rate of smoking cessation. And this is an activity they get reimbursed in what they do. If you just want them to do shared decision making, smoking cessation counseling, these are not a reimbursable kind of visit, at least in the Canadian fee-for-service system. Another thing is we want them to also familiarize how to manage incidental findings, like if you get severe coronary calcification, severe emphysema, etc. So we actually make out a very simple table for them. If you receive a report, just flip it over, that these are the simple things that you do for the next step. So the idea is to save them time, so they don't have to look up things. They can discuss with the patient what do they need to do, make it easier for them. So far, we are just over 1 year of our screening program, province-wide. We actually, although we have an option for people for self-referral for screening, 85% of our screen participants actually referred by the primary care providers. And then we have a steady stream of referrals every week that we monitor that have been very steady in terms of the referral. So I think this is what we find to be useful by intimately involving the primary care providers in the screening program.
So, I mean, I would echo a lot of that, actually. I think most patients do have an enormous respect for their primary care physician and a lot of trust. So if they're wobbling about whether they should come or not, the affirmation from their primary care physician is important, isn't it? But equally, I think even the primary care receptionist or the pharmacist, we put a lot of stuff on their prescriptions, just reminders that this was coming or opportunities and such like. So I think, Laurie, do you want to?
Yeah, and thank you for those who I've not had the opportunity to meet. Laurie Ambrose, and the president and CEO of Go-To for lung cancer, and I am so humbled that the prior organization that I led and now merged into Go-To for lung cancer that has been referenced, because it's been a good 18 years that I've been at this as a patient advocate, and pleased to be able to bring the patient voice into this. And I do have to say that I I don't think it's a successful meeting unless we have shed tears, because those tears are a reflection and acknowledgement of grit, perseverance, and life-saving accomplishment. And to think that we have achieved what we have today with momentum now on our side and a long way to go. It's the research of I-ELCAP and the work of this team that has actually given us as advocates the voice to be able to demand that lung cancer be made a national public health priority, and that the appropriate resources and coordination and ultimately compensation for those who are invested in this work be sustained. So this is a successful conference because we have all shed those tears of accomplishment together. But I'm going to channel Jim Mulshine for a moment and appreciated his, as always, commentary, because we have to ask ourselves why this has been so complicated. There is nothing with a greater magnitude of impact of reducing cancer's mortality than what is before us today. And that is the implementation of lung cancer screening, and certainly the opportunity to navigate our community to new therapies and treatments that have come online in ways these last 5 to 8 years than we've seen in the last 50 years. Why has this been made so difficult? And as a patient advocate, we have to continue to ask ourselves that question, but rely on the work of the researchers and scientists who give us the data and the evidence, and then the advocacy, the political advocacy to do this. Jim Mulshine long said, we have invested in science and medicine. We have directors of the National Cancer Institute. We have directors of the National Institutes of Health. We now have a new ARPA-H that is being stood up in our healthcare delivery system, but there is no national director of implementation. Think about that. There is no one in charge of implementing services and looking at all of these layers in a standard and systematic way that will ensure efficient and effective delivery. It's a political problem more than a science problem in the way we see it. So we've talked so much about many elements around uptake. I won't repeat those, duplicate those. What I'd like to do is focus on 2 other elements and pull Vicki into this, because if you could shift to awareness, acceptance, access, alliances, advancing knowledge, and certainly advocacy. When screening was approved, it was incumbent upon us, since there was no national implementation leadership, to, there we go, to elevate the awareness around lung cancer being a national public health priority. So the awareness is a critical piece in this public health realm. And our work has been around how we educate leadership, both at the federal, state, and local levels, educate them about this development and looking at every angle to bring attention and awareness through these various mechanisms. Sadly, we've seen many public awareness campaigns that only further stigmatize. And so we've got to do a better job the way we message about the excitement and the opportunity, but also the urgency that we have to bear. And we've worked on a number of programs that gladly could explain, but I do think the Shine a Light on Lung Cancer is an interesting element because it engages providers across the country and now around the globe to host events during that month. And we've now had all 50 states represented, over 220 facilities. We've had multiple international communities, and the intention is to continue to build this and grow this as a collective. But this next slide is probably, in my view, one of the most important, and it aligns with what Vicki shared. And Vicki and I go way back in the day, as does Bo Aldeje and the Prevent Cancer Foundation, and our work that literally said, okay, it's not going to happen at the national level, then we need to create a de facto national pilot program that will prove that lung cancer screening can be deployed in a high quality, accessible, affordable way in community settings, because that was one of the pushbacks early on by the naysayers that, oh, this could not be done. It would only harm because communities don't have the ability or capacity. And our work has been to prove them wrong. We now have what is in essence a network of almost 900 hospitals in over 45 states in the District of Columbia that have followed rigorous criteria that has been established, our framework as we referred to it, that embedded quality metrics, criteria. Facility have to be ACR accredited. You had to have a multidisciplinary team that if surgery was going to be conducted, it had to be a thoracic surgeon, a certified thoracic surgeon. Reporting mechanisms that would go back to the patient and the PCP doctor. We also made sure that the guidelines that were followed were NCCN or I-ELCAP. We were collecting data, and I will tell you, since 2015, we have proved the stage shift, the early detection, and all of the benefits that accrue. Smoking cessation needed to be embedded, and we were part of offering research as well. If your hospital was attesting to this and showing this information, you became a center of excellence. And that network is what is the national, the de facto national pilot program, showing it can be done well and right. We worked together on that first opportunity back in Georgia when Vicki was at Wellstar. So the intention now is how we build upon this, not just build out capacity, but to Vicki's earlier point, ensure that the reach and the ramping up of capacity within these hospitals can be supported. So this map is one that we continue to align and look collaboratively on how we can further inform it. The one other element of making sure that we can guide our community to those facilities that we know are doing it well and right is now looking at other elements of excellence that hospitals can establish or work to meet the criteria that we now are establishing in all of these areas. So hospitals can have not just a seal for being a center of excellence around screening, they can also apply to have multiple seals of excellence in these realms. This is all rolling out as we speak, and excited about the process that's underway to make sure that we are continuing to deploy in a very standardized way, in a rigorous way, but in a way in which we can feel very comfortable about directing our community to where we know high quality care. 80% of care is delivered in community settings. If we don't get it right in the communities, then our community will be failed. So this is a critical element of our work, along with so many of the other tools that have been referenced, bringing care to people, trying to break down those social determinants of access. And most importantly, as we have found, is that the alliances locally, our community engagers know their people. And that's who we need to be working with to develop the right educational tools, the way of communicating these opportunities in a culturally sensitive way, things that all of us in our facilities have been working very directly on. The last area, or one other area to mention, is how we are also looking at leveraging other touch points. Most women have OBGYNs as their primary care doctors, and we are working directly with that community to engage in information around access, information around the screening opportunity. Quit lines, another place where we can talk about the screening benefits. And most importantly, what we have found in our network is that we are engaging the PCP community, which has been slow to the table. And I won't go into the bloody work there of getting them to come forward. But we know that when we are working with providers who do have pre-existing relationships with those primary care doctors, that we have greater interaction, relationship building, and successes. The last piece is that, of course, advocacy. The advocacy work is absolutely critical. We've talked here about the need to have important evidence secured and reflected upon, and yet these are barriers that do not have evidence behind them. The fact that we have a 15-year cutoff makes no sense. There shouldn't be an upper age limit. There's no evidence supporting any of this. These are barriers to access. And I won't get started on shared decision-making. No other disease has a requirement that has a significant tobacco underbelly. No other disease. These are the things that we are working on, among many others, in the advocacy space, that we hear from our providers, the challenges that we then can try to take back and address by advocating for changes in our healthcare delivery system, coverage and reimbursement, having had the opportunity to work with our Society of Thoracic Surgeons, ACR, and the like, advocating for the appropriate coverage and reimbursement and reductions of these barriers. So these are so many of the things that are underway that our organization feels humbled to be able to have represented, but it all comes back to the work that's been done here and how we filter that into the channels that reach those very close to the ground, because that's what the work is all about. And our work locally is actually being translated globally. And that's another exciting endeavor to all of this. So our Center of Excellence Network is proving that we can advance uptake, but it's very tailored and very high touched, but it is proving the benefit. The one last piece is I learned just this week. Our work is also trying to infuse a great amount of research funding into the pipeline to support our research community. It's critical. There's been nothing. We secured another 25 million. That's in the first step of the legislative process. But we hope to see what would now be a $225 million flowing directly to the lung cancer research community, with more of that work to come. So it is about the awareness and the acceptance and the access and the alliances and advancing the knowledge of our community and ensuring that our voice is heard as a part of that process. So there you go.
Thanks, Laura. Really powerful, powerful opinions there. It's good to see.
And just getting started.
No, I'm like, and we have to go after that. I just applaud from here.
Just before you do, Vicky, I just want to, does James want to respond at all?
Bill of Rights,
Yes,
because
yes.
this is a stigmatized community, and the fundamental thing is built around respect,
Yes.
that they deserve screening, and that the screening should be excellent. And they should be informed, and it should be a partnership, and all the other respectful things that, you know, I think get missed in so many other ways. One. Two, you know why it took so long. You sat in Baltimore with us, you know, at the Center for Medicare and Medicare Services with many others here, as the advisors said that we don't care if the NLST was positive. This is not safe. We need to do another trial to show that it can be done safely. It's not going to work. And besides, smoking cessation is such a better investment than this. Why would you ever want to do this? And we had such skepticism. And what happened is that, you know, I-ELCAP kind of started it in 99, NLST 2011, randomized trial data. The compounding impact of the excellent results of the Nelson on top of the NLST had an incredible effect of shutting down the skeptics about the inherent value of this approach. And we know that this is changing in terms of momentum, as you said initially. Andy von Eschenbach sent me a Andy Van Eschenbach, the director of the NCI, who signed the check to do the NLST, sent me an email 2 weeks ago at midnight. He said, you guys are getting it done. There's an article in the Wall Street Journal that actually says screening is good. He says, if you got it there, you've done something. So I think it's coming. And I think that, you know, for all the reasons that everybody here does what they do, we guys just got to keep at it. And breast cancer screening took 40 years. You know, you're just getting started.
Thanks very much. Okay, Vicky, do you want to?
Certainly. So for all my fellow Ted Lasso fans will appreciate this. There's one thing I've learned. You do not win a game with one play. So I think there are many or multiple ways that multiple plays are required to actually come together to solve this problem of how do we improve screening uptake. And I've been really studying this deeply over the last few years and thinking it through. And one of the things that I've seen that many of us, and myself included for a while, kind of fell into the trap of, and it's, you know, the four-wall syndrome. We'll build it and they will come. Hey, we built this program and we're not getting any referrals. What's happening here? Can you try to do another study and teach our doctors how to do shared decision-making and refer patients? And the reality is there's really two funnels of patients that are out there, two categories. We do have those that show up at the four walls because they've got a purpose for being there. They're coming in for their annual physical. And not everybody does this. So not everybody shows up for that, or they've got a specific purpose that's driving them there. Usually I'm just sitting there watching TV going, I'm going to call my doctor and get a screening. Usually isn't one of those things, but an annual visit is, or I'm symptomatic for something and that brings them there. So for our patients, they're either coming in, seeing a physician annually, and we try to capture them and drive them up to screening and say, go and have this done. Or we don't capture them because they don't show up until it's too late. And now they're in the ER because that's the only time they ever come in and see a physician or a clinician is when they're sick. So that leaves the other half of the people that we're not capturing, those that don't show up to our four walls. And that's where we have to go to where the people are. So I think outreach planning is really critical and should be a fundamental component when it comes to building out our screening programs. We got to think about where are the people and design and develop processes that actually go into the community to find where they are. So I kind of call that going to where the people are. And the other thing about that is if you're going out there to where the people are, especially some of the real hard to reach populations, is what we have found, and there's research that validates this, is some of these communities, you've got to have health educators that are on the ground, live in these communities. They are relatable to the people in these communities because they are the people that the hard to reach population are going to relate to and trust. And they are the ones that are going to be able to really make a huge impact into some of these communities. And I do think that there is definitely a role for mobile CT in this particular space. I think you have to be very strategic and thoughtful about how it's done. And the example that Dr. Booton has shared is an excellent example of what you're doing there. And I'll have to say, I was really impressed that you actually used the statistic that you found a lung cancer in 1 out of 23 screen. We don't talk like that in the US. Instead, we throw all of this, all these scans, hundreds of scans, and we detect a lung cancer. But the reality is, from my experience of doing this for a long time, thousands of patients, hundreds of lung cancers found, and working with hundreds of centers across the country, pulling those statistics. In the US, a lot of centers tend to find 1 in 30. So, I think that's you're finding a lot of lung cancer there in that population, but it's not feasible for every center out there to own a mobile CT scanner or a van, and not everyone has the money for that. And that's, again, there's many ways for us to solve for that. I think there's roles for that when it makes sense. And then there's opportunities for us to partner together with different organizations or radiology groups or the manufacturers and other partnering healthcare systems within our competing healthcare systems within our own community. There's a lot of lung cancer to be found, and I'd love for us to start having that dialogue of coming together to create some type of mobile screening consortium to help solve that problem in and of itself.
Okay, thanks, Vicky. I'm keen with the 3 minutes left, I think. Matthias, you've been quiet in the corner.
Yeah, only 3 minutes will suffice. Yeah, we are in a complete inverse process. We are the only country in the world that has a special law and legislation on screening as such. So for all kinds of screening. And that means all the discussions that we have here, we have up front before we decide that screening should be done. Now we have the most dense population in the whole world, as you probably know, 555 persons per square kilometer. So you have to go to Singapore, for example, to have a higher figure. And that's really a city more or less. So we don't have the need for all those buses, connections. And furthermore, we have the most dense digital infrastructure in the world. So also the transportation, the high quality, high performance computer centers are very functional. So for me, this is almost a realistic experience. And then, yeah, at a certain point that the Health Council, so those discussions will be in the Health Council. And that will take days, years, even. And then the policy is made. And that is the policy, one policy for the whole country. And then it will be offered in that manner and fully paid for. So, yeah, and from this whole system, which has been so trustworthy already for breast cancer screening implementation and functions already for 20 years, it's extremely difficult to come to the level that you can start implementation. But if you are there, all the resources are there and everything is promoted to do it. So the whole, yeah, it's very centralized. And then because it's like this and the government more or less decides it. So when we start this implementation study, we had a letter of approval of the Minister of Health before you can start. So no personal initiatives, no patient advocacies, no nothing. So that goes all through this Health Council, extremely centralized. When you have the approval, it will all be paid for and it is available for everyone. So I get also the impression that we are one of the most socialistic countries in the whole world because we don't have problems also with the hard to reach population. You saw it, what I presented here. So 40% of our population that we are now screening is in the category of the hard to reach population in the way you describe it. So yeah, I think you should get better legislation in all those countries. It works. For me, it's revealing that it is so different. And I think also the main issue is extremely important, that it is completely covered at the moment you get the approval. So there is no money involved for the participants. They just get a letter that they can join with the address. We have, from a recent survey, we have the GPs. Every person in the Netherlands has a GP within 4 kilometers. I found it amazing.
Indeed.
So we don't have that for buses, not for trains, but we have GPs within 4 kilometers for every person. No, you can even walk 4 kilometers. This is incredible. So
I'm gonna have to try and wrap things up, I'm
Yeah.
afraid.
So
Thanks.
it's completely different.
I mean, I think it's a good note to finish on anyway, because I think my take-home message from a lot of those things you were just talking about, I think that there's a real value in when starting out in a geography for a small pilot. It tells you something about how you need to implement. And I think if we hadn't have done that, you do it in a deprived area, it's different. investment than a more affluent area, different in different countries. You know, so you've got to understand your own local issues for this program, I think. But anyway, I thank you all for your comments. I enjoyed it very much. Thank you very much, everybody. Next session coming.